Welcome to the Georgetown University McCourt School of Public Policy. My name is Sabrina Corlan. I'm a research professor and co-director of the Center on Health Insurance Reforms. For those of you not familiar with our center, we're a team of folks that think about health insurance all day long. I know, very, very glamorous. But in addition to the research that we publish, we also provide technical assistance to federal and state policymakers and have events such as these. We are truly delighted to have all of you here today for this first in a series of events focused on a form of coverage that millions of us rely on, employer-sponsored health insurance, or ESI. This is the backbone of health insurance coverage in the United States, but it is a system under strain. And in this event series, we're going to be exploring the sources of that strain, as well as some of the policy options that are out there to help employers maintain a source of coverage that we rely on and that American families rely on. I particularly want to thank the sponsors of today's event, Arnold Ventures and West Health. They have done incredible work supporting the affordability of health insurance and health coverage. These are incredibly complicated and challenging issues, but they are tackling them head on, and so we thank them for supporting this event. Just a couple of quick logistics before we start. First, we are video recording this event. We'll be posting that recording online, and we'll be emailing it to you after the event is over. And then secondly, we've built in some time for you all to ask questions of our panel. So start getting those questions ready. And when you raise your hand, someone will come to you with the mic. We have for you today an incredible panel, but before I have them come up here and meet all of you, I have the incredible honor and privilege of introducing to you today U.S. Senator Maggie Hassan. Senator Hassan has been representing the state of New Hampshire since 2016, and prior to that, she served as governor. As governor, she led bipartisan work on reducing healthcare costs, attacking the opioid epidemic. In the United States Senate, she serves on the Senate Finance and Health Committees and has led work across the aisle to enact the No Surprises Act, to reduce prescription drug costs, and to tackle our twin epidemics of mental health and substance use disorders. She's just an incredible champion for affordable, high-quality healthcare. So without further ado, welcome, Senator Hassan. Thank you so much for being here.
Well, Sabrina, thank you so much for that really kind introduction, and thank you too for your leadership. And to everyone who is here with the Georgetown Center on Health Insurance Reforms and the team that brings us all together, thank you for your work to help make healthcare more accessible for patients. A special thank you too to the panelists who will be participating in today's conversation. And maybe I'll just jump right into it. I want to take a moment right now to talk about the need for us to end unfair hospital facility fees so that we can bring down healthcare costs, we can save taxpayers and employers money, and we can make healthcare more accessible for more Americans. Everyone who works in healthcare, whether they are doctors, nurses, or administrators, or I can never leave out allied health professionals, they share a common commitment. They will work long hours and do what it takes in order to provide the best possible care to their patients. And I know those values are shared by everybody in this room. We also know that for too long and too often, steep healthcare costs have stood in the way of patients getting the care that they need. Too often, patients are forced into difficult, even heartbreaking decisions between making ends meet and getting life-saving treatments or medications. And the high cost of healthcare forces other difficult choices too. Businesses and taxpayers pay higher premiums and higher healthcare bills than they should, which of course means that critical investments in other priorities are shortchanged. The solutions to this challenge aren't easy, of course, but they really do exist. And I know about some of them thanks to much of the work that you all do here. During my time in public service, I've worked to help bring leaders from both parties together to listen to the experts, to find common sense ways to lower healthcare costs, and ultimately make care more accessible. One of the ways that we can bring down costs is by ending the practice of allowing hospitals to charge patients hospital facility fees when the patients are receiving care in places other than the actual hospital, often away from the hospital's campus, for instance, at outpatient clinics or in primary care offices. This trend has been driving costs higher because many hospitals have been buying community-based independent physician practices, including primary care practices. As a result, many patients have found that even though they are visiting the same facility, receiving the same treatments, or even seeing the same doctor as before, their bills have doubled or more overnight, all because a hospital purchased the practice and started charging fees on the grounds that the practice is now a part of a hospital facility. This burdens both patients and frequently their employers with steep increases in charges for basic services with no change in the quality of care. These dramatic price increases can prevent patients from getting the care that they need or makes them less inclined to book routine preventive care appointments that are critical to catching or treating illnesses early. We need to protect patients by closing the loophole that hospitals are exploiting and requiring the type of transparency that will end this behavior. Already there's been progress in tackling the use of unfair facility fees. Everyday Americans have been speaking out, and thanks to them and the hard work of advocates from across the country, including many people in this room, 11 states have already taken action to regulate hospital facility fees. Building on their momentum, I'm working in the Senate with leaders from both parties, including my colleague, Republican Senator Mike Braun, to pass bipartisan legislation to protect patients from unfair fees. Our legislation would ban, for example, the higher hospital facility fees that providers are charging for basic services when Medicare patients seek outpatient care in hospital-owned practices that are actually out in the communities, not in the hospital. In theory, this practice is already banned, but a loophole in the prior law has meant that it does not help as many patients as Congress intended. The new measure would save seniors from steep, unfair medical bills, and it would save taxpayers money. Our bipartisan bill would also provide greater transparency in the commercial market for patient billing, which the CBO estimated would save billions. Overall, our full bill would save tens of billions of taxpayer dollars over the next decade and would reinvest savings into our healthcare system to strengthen our nursing workforce, an urgent priority for hospitals and healthcare providers, as you all know, all across the country. As you also may know, we recently passed out of the Senate Help Committee the commercial billing transparency provision on a bipartisan basis. And our full bill has strong bipartisan support and support across a broad ideological spectrum of stakeholders. Both Democrats and Republicans are united in this effort because it is a fair, common sense way to bring down costs for patients, employers, and taxpayers, and to ensure that more Americans can get the care that they need. So everyone in this room knows that reforming our healthcare system isn't easy, has never been easy. But it is true that when we actually bring people together and focus on evidence-based ideas, we have been able to tackle big challenges like this one before. And we've managed to make a real difference for patients all across our country. As Sabrina mentioned, and as some of us were talking about before we started, that's of course what happened when Republican Senator Bill Cassidy and I led a successful bipartisan effort to ban the practice of surprise medical billing. I was actually saying that I thought I got a surprise medical bill last week, and I kind of was like I was calling up, like, hey, it wasn't, it was just my deductible. But, you know, I had that moment of like, maybe this is actually helping, the Hassans here. But Republicans and Democrats knew it was wrong for patients to do everything right at a hospital or doctor's office. Find out who's giving you the procedure, how much it's going to cost, the whole thing, call your insurance company. They were doing everything right, only to be hit with a surprise bill, sometimes to the tune of thousands of dollars. Thanks to the advocacy of everyday Americans and to people like Sarah Cliff, whose reporting shined a spotlight on this absurd practice, we brought people together and we were able to make this change, which has already prevented millions of surprise medical bills for patients across the country since it went into effect last year. And it is something, my joke aside, it is something that I hear a lot about from constituents, and it is making a real difference, not only in their finances after the fact, but in their confidence that they can go get the treatment or care that they need without worrying about the impact on their finances and the unexpected nature of hospital expenses. In the same manner, I know that if we work together, if we stand united as Americans and guided by our commitment to do right by patients, we can stop unfair facility fees too. So I thank everyone for being here today, for having this important discussion. The challenges of our health system are vast and they are complicated, that is sure. But when we find common sense solutions like reforming facility fees and advancing site neutral payment, we owe it to patients to try to get it done. It won't resolve all of the issues, of course, affecting our healthcare system, but it will make a tangible difference in the lives of Americans all across the country. And it will help more people get the routine care that they rely on to get and stay healthy. So again, thanks to the Center for your work and your leadership. Thanks to everybody for being here. I hope you have a wonderful conversation today. With that, thanks for having me.
Senator Hassan, thank you so much for being here. And the work that you and your colleagues are doing show that there really is hope and some opportunities for bipartisan efforts to bring down healthcare costs. I'd now like to introduce to you my colleague, Christine Monahan. Her bio is in the brochure that you got when you registered, so I won't take a whole lot of time to talk to you about her, except to say that she is a superstar researcher, a delightful colleague. One of her particular areas of expertise is ERISA, a federal law that governs much of how ESI works today. So she's going to do just a little bit of level setting for all of us to help us understand some of the trends that are driving employer-sponsored insurance and how they're works.
Good morning, all. I can figure this out. There we go. Okay. Good morning. It's a pleasure to speak to you all today about the current state of employer-sponsored insurance. Sadly, however, I do not have great things to say as far as that goes. So, as everyone here is familiar, the cost of healthcare in the United States, particularly in the commercial sector, continues to rise. This is a particularly pressing issue for the employer-sponsored insurance market, which has been described as the backbone of our health insurance system, as it comprises the vast majority of commercial spending and insures nearly half of Americans today, more than 150 million people. Although the rates of employers offering health insurance to their workers and uptake of employer-sponsored insurance in the US population has largely held steady over the past decade or so, it is becoming less and less affordable for both employers and employees. For years now, decades even, premium increases for ESI coverage has outpaced both the rate of inflation and workers' earnings. These differences have been particularly stark for family coverage, to which employers generally contribute less. Both the prevalence and size of deductibles also have increased substantially for the past 10+ years, increasing the amount workers must pay out of pocket for their care. Because of these developments, many employees simply cannot afford the cost of care. In 2019, before the burdens of the pandemic and pinch from inflation had even taken hold, lower income households had less in savings than the typical deductible seen in employer plans. And most households did not have enough liquid assets to meet typical out-of-pocket maximums. That same year, more than 2 in 5 adults with employer-sponsored insurance reported difficulty affording medical care, prescription drugs, or premiums. And when people can't afford care, they delay or put off seeking it, which can lead to worse health outcomes and more costly care. Now, why are commercial healthcare costs going up so much? You talk to any economist or policy expert, and they'll tell you it's the prices, particularly for hospital care and prescription drugs, driven up in large part by the tremendous amount of horizontal and vertical consolidation occurring in our healthcare markets over the past several years. Unfortunately, recent surveys suggest many employers are still under the false impression that it's utilization, and they're getting advice about how to manage their benefit plans accordingly. Now, to elaborate just for a moment on the role of consolidation has in driving up costs, a few things are happening. As hospitals and health systems gobble up more and more of the market, both in terms of acquiring their competitors, as well as outpatient practices and other care settings, they're getting more and more negotiating power over private payers. They are also able to tack on new charges, such as facility fees that the senator mentioned, to a broadening array of outpatient services that used to be provided in independent, lower cost settings. This all leads to higher prices, higher spending, and lower wages. And employers today have limited ability to push back on prices. Part of this is their size. Many are not big enough to demand lower prices, and even jumbo employers are likely to be spread out across multiple hospitals or insurance markets. What's more, employers largely rely on outside vendors or insurers to arrange and run their health benefit plans, whether they purchase a fully insured health insurance plan or self-fund coverage for their workers. And it's becoming increasingly clear that we cannot rely on private health insurance companies to contain costs. Despite insurance companies having engaged in significant consolidation of their own, it is often not in their interest to push back strongly against provider prices. This is partly because the providers charging the highest rates often are considered must-have providers for insurer networks, or these providers have demanded that the insurer include anti-competitive clauses in their contracts. But the major insurers also have little incentive to use what negotiating power they do have, as they generally make more money as health spending increases. This is a particular problem for self-funded employer plans who rely on insurers as third-party administrators. In this role, insurers have little incentive to negotiate competitive provider reimbursement for employers. What's more, employer contracts with insurers and pharmacy benefit managers, with whom many of the insurers have merged, are often rife with hidden fees and overpayments, while the consultants and brokers who employers hire to help arrange their contracts can be taking in massive commissions. This is all happening despite the fact that employers, as plan sponsors, have a legal duty under ERISA to act solely in the interest of plan members and to ensure that they're paying reasonable compensation to service providers, which includes both healthcare providers, such as hospitals, and vendors, including TPAs, PBMs, and benefit consultants. Thankfully, the employer community is waking up to these problems, due in large part to recent efforts by Congress and the executive branch, as well as private organizations, to bring more transparency to our healthcare system. But more still needs to be done to give employers the information, tools, and support they need to become more prudent purchasers. And that's what our panel is going to talk about today. And so I'll turn things back over to Sabrina to introduce everyone.
Thank you, Christine. I'm now delighted to introduce today's panel, moderated by Sarah Cliff of the New York Times. I'm guessing most of you are familiar with Sarah's work, and if you know that her groundbreaking journalism about some of the challenges that patients face accessing and paying for care has really, I think, for a lot of us, changed the way we view our healthcare system and the incentives that drive its participants. So we're really incredibly lucky, and I can't think of a better person to guide today's discussion. For our panelists, we have a great lineup. We have Chris Deacon of Verson Consulting and formerly the head of the New Jersey State Employee Plan. Gloria Sachdev, President and CEO of the Indiana Employers Forum. And Josh Wojcik, Assistant Comptroller for the state of Connecticut. And their full bios are in your brochure, so I encourage you to check them out there. But I will just say that these folks are truly in the trenches, fighting to help the employers that they represent maintain coverage that is affordable and of high quality for their employees. Collectively, they're making tremendous strides, but even the largest employers cannot do it alone. And that's where public policy comes in and why all of us, I think, are in this room. So please join me in welcoming this great panel. I look forward to learning from them. Sarah, I'll let you take it from here.
Wonderful. Thank you. Thank you, Sabrina, for that introduction. Thank you all for being here today and for putting on this event. We only have 20 minutes before we get to audience questions, and we have a ton of expertise up here. So I'm just going to dive right into it and start with the title of the event. Can employer-sponsored health insurance be saved? I would love to have each of you weigh in. How do you think about that? What are the biggest challenges you're facing out there right now in your respective states? Where does it feel like there's progress? Is this a savable system we've built? Gloria, since you're right next to me, I will start with you.
Thanks, Sarah. So, first of all, thank you, Georgetown, for having us here. It's really a great honor for me to be here. I am in the trenches in Indiana. It is exhausting, but it's really important work. We're honored to be part of just trying to make a difference. I think employer-sponsored insurance can be saved. If I didn't think that, I really wouldn't be doing all of this work. We've made headways, right, in the last few years on transparency. We've made some headways on competition, but I think a lot more needs to be done by the FTC. In Indiana, we are trying to address price transparency. We codified some laws in state in addition to the federal work. We're penalizing the hospitals, and we need to penalize the insurance companies as well if they're not going to be compliant with their TIC files. With competition, we recently passed physician non-competes, banning physician non-competes. That was a really big effort. We think that will increase competition so physicians don't have to leave the communities that they're in, and if they want to hang a shingle, as they say in Indiana, outside their window to start up their own independent practice, they can. We didn't get everything we wanted in that space, so we need to do more. So I would encourage the FTC, I know they have a proposal out, but to make sure if nonprofits are not included in the FTC's purview, I kind of hear it both ways. Maybe some of you are nodding, you may have some expertise in that space, that they need to have that level of purview. We've done quite a bit, I think, in accountability, which is good, but price regulation is really our next opportunity. If we don't have price regulation, I don't think ESI can be saved. So in Indiana, we did prohibit facility fees from being tagged on to hospital outpatient services that are off campus, which is defined as more than 250 yards away from the main hospital. So I don't know, people are like, are you gonna get a yardstick? I'm like, well, I need more than a yardstick, I need 250 yardsticks. And so that's what we've been working on. I do feel like facility fees off campus is our first step on our way, I hope, to site neutral.
All right, Josh, how about you tell us a little bit about your viewpoint from Connecticut?
Yeah, so, hearing that question, it sort of reminds me of an old Crosby, Stills and Nash song, Love the One You're With. So, while our one true love may be gallivanting around in Europe somewhere, I don't think employer-sponsored health insurance is going anywhere anytime soon. But I do think that there is some good progress that we've been making. I think something really important that has recently happened is, the new requirement for fiduciary responsibility in the Consolidated Appropriations Act. We just heard some descriptions of, some maybe poor actors within the system, health insurers, pharmacy benefit managers, brokers, et cetera. And I think employers have been blinded to that for a long period of time, but with this new fiduciary responsibility, they're going to have to open their eyes, and they're going to have to hold those players to account. And I hope that starts to change some of those relationships, starts to put a little bit more pressure on hospitals, on providers, to change the market and create more affordability and quality. So I do think it can be saved. I think we have to, and I think we're at least taking some of the initial first steps.
All right, Chris.
So I want to start with a quote by Frank Cummings, who was sort of the designer and architect of ERISA. When speaking about employer-based healthcare, he said, "We may well be doomed to failure. The cost now seems out of control. Employers are generally unwilling to pay these increases time after time." And that was from 2001. Okay. And another just perspective, Zeke Emanuel in 2012, after the passage of the ACA, said that by 2025, few employers would be offering employer-sponsored healthcare, and that 90% of Americans would be in private exchanges. So with that perspective in mind, I think that employer-sponsored healthcare is not going anywhere anytime soon. And I do think the fiduciary responsibility of employers is, I'm just going to correct a little bit, is not new, right? The employer fiduciary responsibility has been around since employers have been sponsors of health plans. They've been without tools and they've been flying blind, right? They've been flying without any information, without data, and completely blinded by some of the brokers and the third-party providers in the space. So if I was to say what I want to see that will transform employer-sponsored healthcare, it is system-wide transparency. So it's hospital price transparency. It's transparency in the private equity's role in healthcare in terms of consolidation, vertical and horizontal. It's transparency in dark money that is headed over to the Capitol, influencing policy and legislation every day that impacts Americans. So system-wide transparency for me is the game changer. And I think litigation is going to have some real corrective moments in the next hopefully few months/years.
I think this might be the first event with a quote from the founder of ERISA and a Crosby, Stills and Nash event. So I feel like we could end it there and be a great success. Gloria, you've been doing so much work in Indiana. Some of you might have seen the Wall Street Journal article from a few days ago. That was wonderful. Tell us, how are you guys, you feel like a bit of a state model, like how are you guys getting mobilized? What are the policy solutions getting traction? It feels like there's some kind of secret sauce you guys have there.
Secret sauce. Well, if it's a secret sauce, I don't have the recipe. But so what are we doing? I will say what's been helpful for us is we bring the data. So we rely on Georgetown's data, and we also rely on a lot of reports. A lot of the academic stuff, I feel like I have to translate it into briefs, 1 to 4 pagers. And that's something that states are going to have to take on, or maybe Georgetown can take it on, or someone's going to need to take on, because it's super time consuming. And the policies are always getting updated, right? There's new journals and new evidence that's coming out. So what's helped us is we're evidence-based. Every slide, every presentation is evidence-based. That's how we won the trust of our legislators, is being evidence-based. Secondly, we brought employers to testify, and that's hard for them. They don't want to be in the newspapers. They don't want arrows thrown at them. So there has to be someone locally in the states that's going to take the arrows, and that is me. I didn't know that when I signed up for this job, but I've gotten a little tougher over time. I still have a ways to go. I still get mad. And so when I can be like these smooth lobbyists that get up there and everything just rolls off their shoulder, like they're so cool. But I still get really mad because I really care about this so much. It's so important. It's harming Hoosiers. It's harming Americans, and showing that data is really important. Getting consumer groups to come and share their stories is really important. And then sharing stories from reporters has been influential. So that's half of it. It's data and employers. The other half, and it's a full half, is lobbying. We have an awesome lobbying partner. It's very easy to say, Gloria, some unknown person to the legislators, is part of the deep state. I don't even know what that means, but I'm part of the deep state. And I can be painted in a certain way, but when you have an influential legislator who's got the ear of leadership, then we have everything. That's what was really helpful. And, we want to thank Arnold Ventures for helping us because lobbying is really expensive. So they helped us on that side. And also we developed a tool called Sage Transparency. Sage Transparency has hospital prices, hospital quality, some hospital cost information, just readily and publicly available to everyone by state. So I think our legislators could just say, hey, this isn't one organization. This is 5 data sources that came together, independent data sources. We just made it publicly available. And they can see how the hospitals in their towns and their communities compare to the state average and national.
Josh, tell us about your perspective running either at least one of the largest, if not the largest plans in Connecticut, and kind of what leverage you have, but also, the challenges you face even as a, very large employer, the state.
Yeah, no, thank you. And so I want to kind of highlight a couple of efforts that we're currently engaged in that I think go along well with this. So really what we're trying to do right now is trying to change some of the nature of our relationships. And just to start with, our relationships with providers. Every time I talk to providers, they sort of say the same thing. What they want for their patients is improved outcomes, improved quality at a reasonable cost. Well, that's what employers who sponsor health insurance plans also want, and what patients want as well. So why is that not happening? Well, one thing that we're trying to investigate this a little bit further, right? We hear a lot of talk about value-based contracting with insurers, et cetera. And we finally asked our insurer, can we see those contracts? Can we understand what are your value-based contracts? What do they look like? What are the incentives, et cetera? And what we're told, to stay on the transparency theme, is that we can't know. So we pay the bills, but we can't know what those relationships are. We can't even know if they're at risk, not at risk, anything. And so what we decided to do was to take the insurer's decision-making out of the middle of that relationship and go directly to our primary care providers and sign value-based contracts directly. And so in those contracts, what we're trying to do is we're trying to share resources. We're going to share risks, and most importantly, we share data, right? Because providers can't make good decisions about where to send their patients, how to manage their patients, if they don't have the information that they need to do that. And when they're working directly with the insurer, they generally don't get it. We're able to share our data and start to change that relationship. We're 9 months into that process right now. We got about 110,000 of our 213,000 commercial lives in these value-based contracts today. I will tell you, this is hard work. This is not easy. It's hard work even from the administrative side, being able to develop the support, the data exchanges, the administrative components, and it's even more difficult, I think, for the provider groups to make those investments, to change their practice patterns, et cetera. So I don't expect changes overnight, but I do think it's the right direction. And I think that's sort of how we need to manage that. In addition to that, we're also trying to change our relationship with our pharmacy benefit manager, sort of the boogeyman, I think, in health insurance coverage. But for too long, I think it's been sort of a cat and mouse game, right? Where the pharmacy benefit managers are trying to identify as many loopholes and various hidden revenue streams as possible. What we're trying to do is create a scenario where we have clear administrative payments, real money that goes to the pharmacy benefit manager, but we align our interests. And there's a lot of talk about eliminating, spread pricing and making sure we get all manufacturer revenue, and that's important. But there's also some other aspects of that relationship where we have a scenario where we have contracts that are based on, get me this many rebates or this level of discount. And we're looking to do away with all of that so that the pharmacy benefit manager can be a partner with us to try to identify where there's opportunities to favor the highest value drug, lowest net cost drug, and then be able to share that information with our prescribers who are now at risk and really try to create partnerships across all of our vendors. So that's the direction we're going. It's hard work. We hope it's going to make a difference over the long term, but that's.
I feel a little overwhelmed and exhausted just hearing about all these initiatives that you're managing, but it sounds like really exciting work. Chris, we're here in Washington, so it feels fitting to ask, how could federal solutions be supporting states, be supporting efforts nationally? What do we need to be seeing from Congress, from regulatory agencies to, make employer-sponsored insurance work better than it does?
So I think there are several bills floating around Congress currently that have seen dramatic changes over the process of reconciliations and markups. From an employer health sponsor perspective, maintaining access to claims data is key. And we thought we solved that with the CAA, right? Section 201 that said employers have to have access to de-identified claims data. But what we've seen over the last 2 years, as this has sort of been debated, is that the carriers are not reading this how employers need this to be read, which is that they get access to their claims data, right? And there are some bills on the Hill right now that would potentially throw into question the ownership of claims data. I cannot stress to you how important it is that claims data and all financial data associated with that claims data be owned by the employer, allow the employer to share that with business associates, right? Without needing to justify it to the carrier. So I think preserving that is key and something we really have to focus on in Washington. And again, sort of the system-wide transparency, I won't mention that again. From a regulatory perspective, enforcement of the regulations that are passed would be great. And we've seen some movement even this week. We saw the enforcement policy on drug pricing come back into effect, which is great. And to Gloria's point, the FTC needs to come up to speed with the times so that healthcare consolidation is addressed, because we know that it is anti-competitive. We have the data. There really is no debate, despite the AHA's, American Hospital Association's continued and relentless statements that healthcare consolidations and mergers improve quality and reduce price. It's false, right? It's not debatable. So I think we really need to do something to address the consolidation. I would say before it's too late, it might be already, right? Certainly in those areas where it is so concentrated that there are no choices, we might have to make some hard decisions there.
Got it. So I'm going to ask one last question to our panelists, and after that, we're going to be opening it up to audience Q&A. So if you have any burning healthcare questions, start thinking about them now. Again, since we're here in DC, all of you have traveled here. What's one thing you want federal policymakers to know about, what they could be doing to improve the affordability of insurance? Start with you.
Excellent. Okay, one thing, because my list has got 20
Yeah.
things on it.
We'll start with like 30
so,
second answers. So
okay,
it's a bit of a
30-second
lightning
answer.
round.
So just as we have now had hospitals and insurance companies, they both have to disclose what their negotiated prices are, right? In the hospital machine readable files and the insurer machine readable files in the Transparency and Coverage Act. Both of those were rules they are looking to get codified. But I don't hear anyone talking about pharmaceutical manufacturer and PBM contracts. I know they're big, have massive lobbying power here in DC, but those contracts, when we say whatever the discounts are that these PBMs are getting, and they're negotiating on behalf of the employer, and they have to get passed down at the point of sale to the patient, at the pharmacy counter or be given back to the employer, whatever the discount is, whether they call it a rebate or a fee or whatever, how do we know if we're getting everything we're supposed to be getting unless there's some transparency in that contract? Josh?
So one thing I was going to say is I would like it to maybe be easier, or maybe there should even be incentives for self-insured employers to participate in state level CMMI demonstration projects. So when we're looking at new value-based care initiatives with Medicare, there's often times a push to get the commercial providers to participate, generally insurers. It would be great if we could have employers actually make a decision. I want to be in, I want to participate, and therefore push the insurers to sort of participate. Whether we're talking about hospital global budgets or primary care investments, whatever it is, I think that would be interesting. It would start to help pull some of those initiatives out of the commercial marketplace.
Chris?
Quickly, health coverage is not health care. And so this is if I got my elevator pitch, right? While lowering the uninsured rate is important, 60% of Americans that have, almost 60% that have insurance are underinsured or are still scared of medical bills. That's a problem. Number two, CMMI, CBO just came out with a report that basically says, CMMI, that the initiatives overall over the last 10 years has not saved money. It has cost the federal government money. And over the next 10 years, it will continue to cost the federal government money, despite the fact that it was a pay for as part of the Affordable Care Act. If we want to pay less for healthcare, we have to pay less for healthcare. Okay, so that's number two. Number three, lead with the largest health plan in the country. The Federal Employee Health Benefits Plan covers 8 million people, spends almost $60 billion a year, and it is run very questionably. Read any OIG report from Office of Personnel Management. They've never conducted an eligibility audit. They allow carriers to run the show without carve-outs for PBMs and with absolutely zero oversight. Lead the way as the largest self-funded employer out there. Those are my 3 things.
All right. We're going to open it up to audience questions. I believe we have a microphone out there. So if you could just tell us who you are, keep your question to a question, and we will get started. So I can ask questions all day because I'm a reporter, but just raise your hand if you have one and we will get to you. All right. Thank you. Someone has to be first. Just give us 1 second, right up here in the front. I think for the video recording, we just want to make sure we get a microphone to you.
Thank you for taking my question. I'm Kara Smith with Inside Health Policy, which is a small, policy-focused outlet. I report on health tech. I have kind of a specific question about telehealth in insurance plans and coverage. I've done a lot of coverage on telehealth as an accepted benefit, which is like a very partisan issue right now, but is set to expire. The enforcement discretion is about to resume in the next calendar year. So I was wondering your opinion on telehealth as an accepted benefit and whether it might increase coverage under employer insurance plans, or whether it's going to, maybe confuse some employees and is just a way to subvert the ACA.
Is there anyone here who'd like to take a crack at that?
I'll take a crack at it. We're really supportive of telehealth services. It has a lot of Indiana's rural, as much of the United States is. And, we need access to, we have a massive amount of consolidation happening in the provider space. So telehealth is a great opportunity for us. What I don't like is hospitals that start up telehealth services and then add facility fees to the telehealth visit. That makes no sense, right? There is no facility fee. So that's an opportunity also for policy, is you cannot tag on a facility fee.
Thank you.
Any other questions? All right, I'm gonna give you guys a minute to think. I'm hoping to hear a few more, but I have more to. So Gloria, you had mentioned something, I think about a lot, which is that, really like at the end of the day, price regulation is going to be a part of it. It made me think of the headlines Christine showed from Uwe Reinhardt's famous Health Affairs article, it's the price is stupid. It also feels like kind of the white whale in a way, like the thing that makes our healthcare system so different from others. How do you think about getting there? Are there things we're biting off? But, and, Josh and Chris, feel free to weigh in, but kind of where does price regulation fit into the American system? Because it seems like something we're often very, very allergic to and kind of my reporting experience.
Yeah, in Indiana, we are allergic to it, right? We were like, we don't want a price cap. So I was calling it a price ceiling for a while. And people don't want price ceilings either. But, this is what I did. We took the prices of all of our hospitals, systems, and individually put them on a curve, we just plotted them, and there's a bell curve to it. And I was like, can we cut off the drag, the snake's neck, if you will, right? And just put a cap on, even if you want 300% of Medicare. Actually, in Indiana, it'd have to probably be 350% of Medicare. So it's 3.5 times what Medicare is paying for the exact same service at the exact same hospital. I mean, that's not fair. And in the communities that's happening in, we have these massive monopolistic hospital systems. They can charge whatever they want. So I am in favor for it because we have, for 21 years at the Employers Forum of Indiana, been applying market pressure, and it's not working. So now we are applying political pressure, and that is helping. I think Chris's point of litigation will also help, but I don't see any way around it without some sort of price.
Yeah, Chris?
So I grew up in Florida, and Florida, like 24 other states in the country, has specific rules and regulations about price gouging after crises, hurricanes in Florida, right? So we don't have price regulation on water, but when you absolutely need water and water is limited because a crisis or disaster has happened, there are laws in place that say you cannot charge $100 for that pallet of water, right? So I want to analogize that to the mom whose daughter has just been diagnosed with cancer. She wants and needs the best care for her daughter. How is she different from the person that needs that water? It is a crisis, right? And I'm not saying we should regulate this as like a disaster, a crisis, and fit them into that model. But what I'm saying is there is precedent in the US, and we live with it, and we are proud of it, right? That in certain situations, price regulation is absolutely appropriate.
Just one thing I just wanted to highlight as we think about sort of price regulation, what does that mean? What does it look for? I think we also should be keeping in mind, that we want to pay for what we want. And what I mean by that is, right now the system rewards sort of high profit services. Like we don't need any more orthopedic surgeons. We have enough. We do. Cardiologists, we got enough of those too. But we do need behavioral health providers. We do need primary care providers. We do need folks who specialize in geriatrics, but we don't pay for that today. And so I think as we think about price regulation, it's pulling prices down, but it's also pulling prices up in certain areas. And so just something I think that should be kept in mind.
Any audience questions? Yes, right there. Gloria, I feel like this was tailor-made for you because you guys do seem
Yeah.
to have the employers engaged.
We do. We don't have all the employers engaged. We actually probably have a handful of employers engaged. It's really tough. Why is it tough? So, and what are the opportunities there? So it's tough because most of us, so I head up a business coalition in Indiana. It's employer-led. They're on my board and my executive committee, but we're multi-stakeholder. So we have all of these parts and pieces, the supply chain, if you will, that are members as well. But we're dealing with benefits people, okay, whether they're managers, directors, VP, HR, human resources. Most of them don't report to the CFO. What we really need to do is get the C-suite engaged. You know, they think healthcare, it going up 6, 8, 9, 10, 15%. Oh, well, you know, like they don't know what to do about it. And they don't treat anything else in their business like that. They know where every penny is going. So we need to engage the CEOs, CFOs, and I would really, you know, I'm excited in a couple of weeks. It's making headlines, if you will. So it's now it's a mainstream conversation. And so they invited me, 30 CEOs invited me to come present to them on healthcare. And that's never happened before. So I think we're approaching a tipping point, but in everyone's communities, they really need to figure out how to get to the C-suite. It is hard because, you know, a lot of HR folks, their job is to keep the noise below them and not get to the C-suite, right? If there's going to be disruption and get to the C-suite, then their job may be at risk, right? Like, why am I hearing so much noise when the top echelon doesn't even understand what's going on with healthcare? So what really needs to happen is the C-suite needs to resource the HR folks better with data analytic folks and clinical informatics folks. I have a bunch of employers and one of them has a chief medical officer. That's it. They know they need to start looking at their data, but they'll say, well, what are the data inquiries I should ask, you know? So they don't know what a hemoglobin A1, so for diabetes, they don't know really how to monitor it, chronic diseases, whatever they're looking at. And so they need more resources, but they can't ask for it. We collectively are going to have to start doing a better job educating the C-suite.
Yeah, I'd love to hear from Josh and Chris kind of on the state plans and kind of you're such large employers or previously running a state plan, how you think about that.
Well, I was gonna say less from the carrot side and more from the stick side is, you know, we will wake up to a day when some of these lawsuits, you know, some of you might be familiar with, Kraft Heinz versus Aetna, Mass Laborers versus Blue Cross Blue Shield of Massachusetts, and then Bricklayers versus Anthem. There will come a day when those cases are decided and there's two options, right? Either the carriers are holding fiduciary liability, and if you have any of those carriers, you better giddy up and hold them to account, right? Because you're now on notice that these things are happening. Option two, the judge says no standing, no fiduciary liability on the part of the carrier. You're the fiduciary. Well, in that case, you're going to have class action attorneys picking up the phone and calling employees and saying, your employer hired Aetna, hired Anthem, hired whomever, and has failed in their fiduciary duty because they are not holding them to account. And they're going to form a class and sue the employer. The day when the C-suite and the business community recognizes that health benefits today is one of the largest hidden risks on their financials, I think we will begin to have engagement. So that's sort of on the stick side.
Yeah, just to follow up, I've seen the ads. I have pictures of the ads. It's with State Farm and PetSmart and who's that?
Target.
Target. Oh, Target.
Target's
with
a Target. Yeah.
Is a Target. So it does. It's these attorneys trying to get their employees to sue the employer, which is, you know, I think as soon as some of those happen, and these are really big attorney firms. These are the ones that went after the tobacco. So they know what they're doing.
Any other questions out there? Yeah, right here.
Stuart Hagan with the Blue Cross Blue Shield Association. So I want to change the focus a little bit now. Shifted. I was reading this morning an interesting article in the Washington Post about declining longevity in our country, which is become really growing more and more. And I'm thinking about it from the perspective of ESI. I'm wondering if you think about as you, the involvement you have in it. Do you think of it? It seems like the conversation has been about cost, which is definitely an important part. But do you consider, are you managing cost, or are you thinking about it also from the standpoint of improving the health of employees? You know, one of the arguments in favor of ESI, self-insuring, one of them is that employers then have, they have a reason to want to improve the effectiveness, productivity of their employees, have fewer fewer lost work days. Just curious how much that actually enters into the calculus.
I don't know, Josh, do you want to speak
Yeah.
to that?
Yeah, no, I think I can. And so, I mentioned before, sort of the direct contracting with primary care groups. The part that I did not mention about that is one of the big components is providing them with additional upfront resources. So we increased their care coordination fees over what the carriers were providing by 500%, and increased their total revenue from the state employees plan for, if you take into account everything they receive, care coordination, fee for service, et cetera, increase their total revenue by 50%. The objective of that is so that they can actually make some upfront investments in care coordination, care management, et cetera. I'm going to be frank with you, and the literature would bear this out. That's not likely to save money in the short term, but it can have positive impacts on our members' health and health outcomes, and that's important too. So, I think as we're thinking about how to manage a health plan, it's cost and quality, and how do we get there? Unfortunately, today we're paying a lot for the wrong things, and we need to change that.
Yeah, I would agree. I mean, having run the state plan, we led with what's right for the members, right? And today in employer-sponsored healthcare, we've seen a dramatic shift over the last 10 years to high deductible health plans because we've had to cost shift to employees. And when you do that, when you don't address costs and you have to shift to the employees, they avoid care. They avoid going to their primary care, or they can't find primary care. So we're getting a lot of really expensive sick care when we should be investing in more healthcare. But I would say, healthcare is one of those areas that you don't have to spend more to get better quality care. In fact, the inverse.
Are there other questions out there? Yeah. Just right here in the aisle.
Hi, Mike Butler. I'm a recently retired CHRO, so voice from the C-suite, and I can absolutely confirm a lot of what you guys have said. I'm curious, when you think about the cumulative effect of legal pressure, I think that's correct, cost pressure, is there a point at which you think employers might throw up their hands and say, this is not my fight, this is not working for us, and looking for alternatives? And I'm thinking about ICHRAs in particular, maybe at the smaller end initially, but then potentially beyond that. I can tell you for a fact, if I had applied one to my CEO, my CFO, said we need to build a data analytics department to manage our healthcare, the first response would have been, what's the alternative? Because that's ridiculous. We're not.
Yes, so that's a concern I have. I'm concerned that healthcare is so complex and so confusing that employers can't figure it out on behalf of their employees, and working with all the partners, the PBMs, insurance companies, hospitals, providers, et cetera. And they will. I already have employers that are saying, I'm done. I'm fed up. I don't know. We can't control this. It's just getting worse. And everyone, I'll just put money You know, the average Christine showed is $22,500. I'll put that in an account. Good luck. Go on the, you know, ACA marketplace and go buy your own insurance. Now you've just dumped it on your employee to go figure it out. They may pick the cheapest plan, right? Because they just don't understand even what's involved in that. And then you just play that out. So they get the cheapest plan. And now they're on a high deductible health plan, right? Because those are the ones that are going to have the lowest. Are we just going to see even less and less people access care, and health and quality even get worse and worse over time? I mean, I don't see that as a positive path. I can't see that. I can see employers doing that, but I can't see that being good for society. But they are fed up, and that's why, that's why I'm here. You know, that's why I'm part of the conversation. I think if we just put in like the 20 things that all these little things in place, unfortunately, we're just going to have to run them all down. You know, I wish there were like 3 things and we could just all work on those 3 things, but there are a lot of pieces in there. So you're a CHRO, you know, I think we can just start. I tell our employers, just start with clinical informatics. You know, just get one person who understands the clinical side and the data side, and maybe you guys can share one person, you know?
I think we've run through all our time for questions. I think Sabrina will come back out to for some closing remarks.
Thank you so much, Sarah, and thank you to our panel. I hope all of you learned as much as I did and are taking away from this some ideas and inspiration for policy. And I do, as much as this conversation is a bit depressing, I also see some real bright spots and opportunities. So I want to thank our panel. Just a couple of things. We do have the video of this event that we'll be posting online. So please look out for that and share it with any colleagues who couldn't attend themselves. And then the next event in our series will be February 27th. So stay tuned for some details on that in the months to come. Please thank our panel. They've really been